Welcome to this training on using data with a strategic prevention framework planning process. This is part one of the training. The second portion of the training will be conducted via Zoom at the end of January. If you have not signed up to attend one of the live sessions, please do so as soon as possible. To register, go to the email from the Behavioral Health Division of the Indiana Criminal Justice Institute. You will find a link in that email to the registration form. This training is brought to you by the Great Lakes Prevention Technology Transfer Center. The Great Lakes PTTC, for short, is funded by the Substance Abuse and Mental Health Services Administration through a cooperative agreement located at the University of Wisconsin-Madison Center for Health Enhancement System Studies. All material appearing in this presentation is in the public domain and may be reproduced or copied without permission from SAMHSA or the Great Lakes PTTC. The opinions expressed in this webinar are the views of the speakers and do not reflect the official position of the Department of Health and Human Services and SAMHSA. So, what is it about data that is so important that we need to take the time to do a two-part training on it? Well, because it helps us make sound decisions in several areas of planning, thus increasing our ability to successfully prevent substance misuse. More specifically, data helps us make decisions in the following areas. First, it helps us increase the likelihood that our efforts will result in positive outcomes. Second, it helps us decrease the likelihood of wasting scarce resources, including human, fiscal, and organizational resources. Third, it helps ensure that we are focusing on addressing the problems of highest priority in our communities. Fourth, it also ensures that resources are allocated based on who in our communities needs them the most. And finally, when there are subjective opinions regarding what to be done, data can help you arrive at decisions. Data helps with decision-making by answering questions we have. For example, data can help us answer questions such as, what substances are being misused in our community? On which populations should we focus our efforts? What risk factors are driving the problem in our community? And what prevention strategies should we adopt? Data also helps us create a roadmap for how to deliver substance misuse prevention services. This roadmap is called the logic model. It's a logical way to connect the problems identified by communities with the specific factors in their community that are influencing or contributing to the problems, with the interventions they will use to address the problems. Logic models also specify the short-term and long-term outcomes we will use in the evaluation of our prevention programs. Because this logic model provides a map of the process, you will notice that I will be referring back to it throughout this presentation. One planning process that can be used to incorporate data into strategic planning is the Strategic Prevention Framework. The Strategic Prevention Framework, or SPF for short, is just a fancy name for something we do every single day of our lives, strategic planning. We actually use strategic planning even if we don't realize we are doing it. We use it when planning a party or a vacation, or when working toward a big goal, such as getting a master's degree, learning a new language, or losing 15 pounds. We use it naturally. The Strategic Prevention Framework simply puts some structure and terminology around the process and offers some tools to help communities move through the process smoothly. As you will see on the slide, the SPF consists of 5 steps: assessment, capacity, planning, implementation, and evaluation. Incorporated into each step are sustainability and cultural competence. That's why you see those two in the middle of the graphic. In this training, we will explore how data is used as a decision-making tool in every step of the SPF. An example of how we use strategic planning in everyday life that I love is from a fellow trainer of mine, Pam Tyndall. A few years ago, she decided to plant an herb garden. She first did an assessment by answering a series of questions, including, what kind of a garden, raised bed or border garden? She decided to plant a circle garden. Where should she put it? It needed southern exposure, so she decided to put it by her barn. What is the condition of the soil? It's by the barn, right? So yeah, it's great soil. When should she plant it? Early spring. So those were all of her assessment questions and answers. Next, she looked at capacity. She checked on the resources she had already and found that she had good soil, a trusty garden fork, drip hose, an herb book, and $100 to spend. She also found some resource gaps. She needed to rent a sod cutter and buy drip hose connectors. So that was the capacity step. Next, she turned her attention to the planning step, figuring out and completing the following action steps. Buy hose connectors, rent sod cutter, remove the sod, fork the soil, buy perennials including sage, thyme, rosemary, and oregano, and buy annuals including parsley, basil, chives, and cilantro. So now it was time to move on to implementation. This included planting the herbs and hooking up drip hose. Finally, she moved to evaluation. She evaluated the success of her garden. Short-term outcomes? Well, the parsley and cilantro were eaten by deer. She realized she needed a deer fence. Long-term outcome? The following year, she transplanted perennials around the edge because deer don't eat them, and annuals in the center of the circle. All survived, were tasty additions to her family's diet. So we can take this same planning process that we use in everyday life and apply it to our substance misuse prevention programs to increase our effectiveness, just as Pam did with her herb garden. Many of you work across the substance misuse continuum of care spectrum, including promotion, prevention, treatment, and maintenance. For the purpose of this training, we will focus on the prevention portion of the continuum of care. Prevention focuses on strategies, programs, or interventions that occur prior to the onset of a substance use disorder. In other words, it is the work we do to reduce the risk of substance use disorder. So keeping in mind our focus on prevention for this training, let's take a look at how we can use data to inform our prevention planning efforts during step 1 of the SPF, assessment. This first step of the SPF is important because it provides us with the opportunity to use data to identify the priority substance misuse problem and/or related behavior. For example, in one community, their assessment data might show that the problem that needs to be addressed is underage drinking, while another community might find that opioid misuse is the greatest priority that needs to be addressed. Data also provides us with the ability to identify the priority risk and protective factors. Data is collected on risk and protective factors in this step of the SPF. However, the analysis of the data will occur during step 3 of the SPF, planning. So we will revisit risk and protective factor data again in a few minutes. Gathering data on substance use and its associated problems helps us answer the questions such as those on this slide. What are the problems and related behaviors that are occurring in the community, including the consumption patterns and consequences our people are experiencing? How often are they occurring? Particular times of the year, seasons, frequency? Where are they occurring? Are there places in our community where specific problems are occurring more often, such as neighborhoods, schools, workplaces, locations such as parks and woods? Which populations are experiencing them more? Specific age groups, genders, sexual orientations, rural, urban? To answer these questions, we gather data to help us understand the substance misuse problems in our community. So you might be wondering, what data can I use to complete step 1 of the SPF? The local coordinating councils in Indiana are very fortunate to have a lot of data at your fingertips. In Appendix A of the Local Coordinating Council Policies and Procedures Manual, you will find 7 sources of data that's available at different geographical levels. I encourage you to explore all of the data sets and pull out the data that is most useful and applicable to you and your communities. Once you have collected the data using sources mentioned on the last slide, it is time to make sense of it all by analyzing it. Through this analysis, you will determine the priority problem to address in your community. Various criteria can be considered when selecting which problem is your community's priority. You will want to make sure you have data collected that allows you to examine the criteria and corresponding questions found on this slide. When analyzing your data, you will want to consider 4 things. First, magnitude, or in other words, which problem seems to be the largest. Next, you will want to look at time trends. Is the problem getting worse over time, or is it getting better? Next, consider severity. What is the severity of the problem? Is it resulting in mortality? Is it more costly? Finally, look at comparison. How does the community's problem compare to surrounding communities or the state? Let's delve into comparison a little more on the next slide. These are some of the ways you can analyze your data in terms of making comparisons. You can examine comparisons in the following ways: between now and sometime in the past, between your community and the state, or your community and similar communities, among different population groups within the community, such as different age groups and genders, or between a group and one of its subgroups, such as all immigrants versus Southeast Asian immigrants. I have a caution for you though when making comparisons. Be sure to take small numbers and percentages into consideration. For example, if there was a 100% increase in motor vehicle crashes caused by drivers under the influence from 2018 to 2020 in your community, what would you think? Your initial response might be that this is of great concern. However, if there was one motor vehicle crash caused by a driver under the influence in 2018 and 2 in 2020, you might come to a very different conclusion about this as a priority to be addressed in your community. So when using small numbers and percentages, it may appear as if there has been a significant increase, but when looking at the actual numbers, the increase is very small. So again, use caution with small numbers. So far, we have been focusing on quantitative data. However, it is important for communities to consider both quantitative and qualitative data when conducting their assessment. Quantitative data are typically numbers. This is the type of data referenced in Appendix A of the Local Coordinating Council's Policies and Procedures Manual. Qualitative data are typically words. Sources of qualitative data can be focus groups and surveys with open-ended questions. By including both quantitative and qualitative in your community's assessment, you will have a more complete picture and understanding of the substance misuse issues in your community. Remember the logic model I mentioned a little earlier? Once you have completed the data collection and analysis for step 1 of the SPF, you will have the information you need to fill in the first box of the logic model. That is the priority problem or related behavior in your community that needs to be addressed. An example of a problem behavior that some communities have identified as a priority problem behavior is underage drinking by youth who are ages 18 to 20. You will see on the slide that I included that in the blue box on the second row to the left. We will build on this example during this training. Let's turn our attention now to step 2 of the Strategic Prevention Framework, capacity. What do we mean by capacity? Capacity in the world of SPF includes the resources and readiness for substance misuse prevention that exist in your community. Consequently, in this step, we will focus on collecting and analyzing data related to your community's resources and readiness for substance misuse prevention. Let's look at resources a little more closely. When examining your community's capacity for substance misuse prevention, you will want to identify what resources currently exist in your community to address the priority problem identified in Step 1 of the SPF, as well as what resources are still needed. Resources typically fall into 3 areas. First, fiscal, which includes both funding such as grants, as well as other things that cost money but are obtained for free, such as meeting space, food, and advertising. Second, organizational resources refers broadly to the structures within an organization that are deeply connected to a community's substance misuse prevention goals, such as vision and mission statements, as well as guidelines for decision making, and also clear and consistent organizational patterns and policies. The third area of resources is human resources. This includes people who can assist with prevention in some way. This can be paid staff, volunteers, key stakeholders, and others. In terms of readiness, it is essential to identify how ready your community is for substance misuse prevention efforts. Is your community in denial? For example, regarding underage drinking, is there a norm of kids will be kids, I drank when I was a kid and I turned out just fine? Or is your community at a higher level of readiness where they have accepted that substance misuse is an issue in your community and they are ready to take action? It's essential to know this before implementing prevention efforts, because if your community is not ready for prevention, you will experience many challenges trying to implement prevention programs or strategies. As you can see on this slide, stages of community readiness range from no awareness and denial and resistance to expansion, confirmation, and community ownership at the highest level. You can find definitions of each stage of community readiness in the Triethnic Center's document. It's a fantastic resource for you to use when collecting and analyzing data on community readiness. It can be found at the website listed on this slide. It includes survey and analysis tools, as well as strategies to improve your community's readiness based on what level you are at. And back to our old friend, the logic model. So where does capacity fit into the logic model? It actually encompasses the first 3 boxes of the logic model, because a community's resources and readiness will impact if and how you will be able to address priority problems, priority risk and protective factors, and what prevention strategies or programs you can implement. That is why it is essential to work on collecting data on capacity at this step of the planning process. Once you have completed steps 1 and 2 of the SPF, assessment and capacity, it's time to move on to the planning step. 3 tasks need to be completed during the planning step of the SPF, including prioritizing risk and protective factors, using that data you collected during step 1 of the SPF, selecting evidence-based programs, strategies, or interventions to implement based on research data, and third, develop a comprehensive data-driven plan. Let's look at each of these tasks one at a time, starting with prioritizing risk and protective factors. So the first task of step 3 of the SPF is to use data to prioritize risk and protective factors. 2 criteria can be used to help you prioritize which risk or protective factor you need to address in your community in order to address the priority problem that you identified in step 1 of the SPF. Let's look at these 2 criteria, importance and changeability, one at a time. Importance looks at how much a risk or protective factor is impacting the problem in the community. To help determine the level of importance when examining the data collected, you need to ask the question, how important is a particular risk or protective factor in reducing the problem in our community? If the answer is very important, then this would be considered high importance. If it is not very important, then it would be considered low importance. For example, with the problem of underage drinking, if your community's data showed that lots of youth are obtaining alcohol from stores, referred to as retail access, rather than from their homes or peers, referred to as social access, then retail access would be considered high importance, whereas social access would be considered low importance. Another factor to consider when weighing the importance of a risk or protective factor is its influence on other behavioral health issues. Does the risk or protective factor influence other behavioral health issues, such as school dropout, violence, teenage pregnancy, or depression? The importance is considered higher when a risk or protective factor influences multiple behavioral health issues. One other factor to consider is a risk or protective factor's impact on certain developmental stages. Does the risk or protective factor directly impact the specific developmental stage of the population group that is experiencing the problem? For example, if your community's priority problem is underage drinking among 18 to 20-year-olds, then the risk factor low parental monitoring around drinking behavior would have less impact for this developmental stage than it would for a population of 14 to 17-year-olds. So parental monitoring, in this case, would be considered low importance. The other criteria to be used when prioritizing risk and protective factors is changeability. Changeability explores the following. Does the community have the capacity, the readiness, and resources to change a particular risk or protective factor? Is there a suitable evidence-based intervention that will address the risk or protective factor? And is it possible to change the risk or protective factor in a reasonable time frame? Changing some risk or protective factors may take too long to be a practical solution. So a risk or protective factor would be considered to have high changeability if the community has ample resources, there's sufficient readiness to address this risk or protective factor in the community, a suitable evidence-based intervention exists, and change can occur within a reasonable time frame. It would be considered to have low changeability if resources are inadequate or the community is not ready to address the risk or protective factor. Once you have found a risk or protective factor that is of high importance and high changeability, you will have the information you need to fill in the second box of the logic model. Let's check back in with our logic model example. This community found that the risk factor of retail access had high importance and high changeability. Consequently, they are going to work on reducing the prevalence of this risk factor in their community in order to reduce the likelihood of underage drinking by 18 to 20-year-olds. So once we are done with the first task of the planning step, prioritizing risk and protective factors, we move on to our next task, selecting an evidence-based program or strategy. 3 questions need to be answered when selecting your intervention. First, is there evidence of effectiveness of this program or strategy? Second, is there good conceptual fit, meaning will the intervention impact the priority risk factor? And third, is there good practical fit, meaning is it feasible for the community to implement the intervention? Let's look at each of these questions separately. Okay, let's take a look at evidence of effectiveness. Evidence of effectiveness refers to whether the intervention has evidence. Is it based on research showing that it is effective? It is recommended that you start by reviewing federal registries of evidence-based interventions. These typically have strong review processes in place. If you cannot find an appropriate program or strategy in the federal registries, then the next best step is to look for appropriate programs or strategies in peer-reviewed journals. Finally, if you still can't find an appropriate program or strategy, then you can review programs and strategies that have documented effectiveness that's supported by other sources of information and with a consensus of experts. For example, for certain populations, there may not be many interventions that are evidence-based. For example, there are few evidence-based programs for Indigenous or certain immigrant groups that are in federal registries or in peer-reviewed journals. In this situation, you might consider looking for other sources of documented effectiveness. Overall, it's important to consider whether the evidence of effectiveness for an intervention is weak or strong. When selecting interventions, be sure to give priority to interventions that have a strong evidence of effectiveness. After reviewing the data on evidence of effectiveness, you will need to look at conceptual fit. Conceptual fit considers how well an intervention does three things. First, how well does it address the priority risk and protective factor as well as the priority problem behavior? Second, how well does an intervention produce positive outcomes with substance misuse or risk and protective factors? And third, how well does the intervention target multiple contexts such as individual, family, school, and community? It is important to note that if the intervention does not address the risk and protective factors that influence the substance misuse problem your community has selected, then the intervention is unlikely to produce the positive outcomes you are looking for. Consequently, finding a program or strategy to implement that is both has evidence of effectiveness and has good conceptual fit is essential. Once you have looked at data on evidence of effectiveness and conceptual fit, the third task in selecting an intervention is to examine practical fit. Practical fit refers to the appropriateness of a specific intervention for a specific community. If the prevention program, policy, or practice does not fit the community's capacity, resources, or readiness to act, then the community is unlikely to implement the intervention effectively. The following questions help determine the practical fit of an intervention. First, is it feasible? Does the community have the resources, such as human, organizational, and fiscal resources, needed for the intervention? Second, is there synergy? Does the intervention add to or reinforce other prevention interventions? Third, is the community ready? Will stakeholders and the community support the intervention? And finally, is the intervention culturally relevant? Will the cultural groups that are the focus of the intervention be receptive to it? Are they involved in the planning and implementation? All of these questions must be answered when determining practical fit. Once you have found a prevention program, strategy, or intervention that is a good practical and conceptual fit and has evidence of effectiveness, you will put the name of that strategy in the interventions box of the logic model, right there in the middle. Let's check back in once again with our logic model example. This community found that the strategy of alcohol retailer compliance checks was found through research to be effective at reducing the risk factor of retail access to alcohol, as well as reducing the likelihood of underage drinking by youth ages 18 to 20. Consequently, the strategy has strong conceptual fit. The community also determined that the strategy is feasible to implement, is culturally appropriate, and that there is high community readiness for this strategy. Consequently, the alcohol retailer compliance check strategy is a solid practical fit for the community. So I've gone ahead and entered it into our logic model in that middle box on the second row. Now that we have completed the assessment, capacity, and planning steps of the SPF, we can turn our attention to step 4, implementation. Let's take a look at how data is used during this step of the planning process. Data is needed in this step of the SPF process in order to monitor the implementation of our prevention program or strategy. More specifically, we will want to collect data while we are implementing our prevention efforts so that we can know whether or not they have been implemented as designed and planned. If any adaptations are made to a program or strategy, these should be documented, including information on how the decision was made to make the adaptations. This data will be very helpful when evaluating your prevention efforts, as well as for making mid-course corrections as needed. Returning to our example, this community would collect data while monitoring their implementation of the alcohol retailer compliance checks. They would collect the data necessary to show whether or not the compliance checks were implemented as designed and planned. Monitoring the implementation of your prevention efforts leads us right into the last step of the SPF, evaluation. Data will be used from your evaluation for 3 purposes. First, to monitor the implementation, building off of your work in the last step of the SPF, implementation. Second, to improve how well your prevention efforts are implemented. And 3, to inform future decisions regarding your substance misuse prevention programs and strategies. Your evaluation data will inform future decisions by helping you understand what worked well so that you will want to continue those efforts. And it will also help you identify what didn't work so well that you might want to consider discontinuing or modifying in the future. The evaluation step of the SPF will provide us with the information needed to complete our logic model through both process and outcome evaluations. Let's look first at process evaluations. A process evaluation helps you determine whether or not your prevention program or strategy was implemented as intended. This ties into the task of monitoring implementation during the implementation step of the SPF. Process evaluation looks at the details of implementation. It answers the question, did we do what we said we would do in the implementation of our program? For example, was the same material presented in the same number of sessions over the same time frame using the same methods? Process evaluation data can help inform why results or outcomes might or might not be met and where to focus on making any mid-course corrections. This slide includes an example of what process evaluation data can show. In this community, they implemented a prevention program with a planned target population of 6th graders, but they only implemented 12 of the 15 sessions, used outside consultants with no training instead of teachers who received training on the curriculum, and they did not implement the booster sessions in 8th grade. By documenting and understanding the differences between planned and actual implementation, this community will better understand the results of their outcome evaluation, which we'll talk about next. For example, if their outcome evaluation shows that the program was not effective, the process evaluation can give them some clues as to why it wasn't effective. In this case, it is because they did not implement the program as designed and planned. Outcome evaluations document whether the intervention made a difference, and if so, what changed. Outcome evaluation documents the effects achieved after the implementation of a program or strategy. The effects can include changes in knowledge, attitudes, skills, or behavior. Outcome evaluation includes both short-term and long-term outcomes. What is the difference between short-term outcomes and long-term outcomes? Short-term outcomes are typically a change in skills, knowledge, and/or attitudes. Examples of these are problem-solving skills and unfavorable attitudes toward drug use. Short-term outcomes are related to risk and protective factors for substance misuse. The reason it is important to measure short-term outcomes is because a change in skills, knowledge, and/or attitudes typically precede a change in behavior. Long-term outcomes are typically behaviors or consequences. For example, a reduction in prescription drug misuse would be a long-term outcome. Long-term outcomes are the so what as to why we pour our time, energy, and funds into substance misuse prevention. Let's take one last look at our underage drinking example. In this last step of the SPF, we can add in the short-term and long-term outcomes. The short-term outcome could be to reduce the number of alcohol sales to 18 to 20-year-olds. You will see that the short-term outcome relates directly to the risk factor of retail access to alcohol, as it should. The long-term outcome is to reduce underage drinking by 18 to 20-year-olds. You will notice that the long-term outcome is directly related to the problem behavior as listed in the first column, again, as it should. I purposefully shaded the problem behavior and long-term outcome boxes the same color, blue, because they should be directly related to one another. And I shaded the risk and protective factor and short-term outcome boxes dark green because they should be directly related to one another. If you correctly link these boxes to one another, along with the intervention box in the middle, then you will have a strong logic model. We covered a lot of ground in this training, so just to recap, we have covered how we can use data with each step of the strategic prevention framework. In step 1, we use data to assess and prioritize substance misuse problems and related behaviors, and you collect data on risk and protective factors. In step 2, data is used to assess and build our community's resources and readiness for substance misuse prevention. In step 3, we use the data collected in step 1 to prioritize which risk or protective factors we need to address in our community. We also use data to select which prevention programs or strategies we should implement. And finally, we develop a comprehensive data-driven plan in step 3. In step 4, there are multiple tasks to be done, but the one that involves the collection and use of data is monitoring implementation. And finally, in step 5, we use data when conducting our process and outcome evaluations. Thank you for joining me for this training and for the valuable prevention work you are doing on behalf of your community. I do look forward to seeing you during the live training on Zoom in January.